Hey, good afternoon, everyone, and welcome back to Grand Rounds. Today it is my pleasure to introduce Dr. Patricia Quinliks. Dr. Quinliks received her MD degree from the University of Wisconsin Master of Public Health from Johns Hopkins. She holds faculty appointments at the University of Wisconsin, Iowa State, and the University of Iowa, and I guess most germane to today's presentation is that she was the Iowa State epidemiologist and medical director for the Iowa Department of Public Health from 1994 to 2018, and she has very graciously accepted our invitation today to provide us with a review of pandemics, Iowa and the world, and please join me in welcoming Dr. Patricia Quinliks.
Well, thank you very much for having me. So I'm going to try to talk a little bit about the pandemics that we've seen in history, certain things that we've learned from those pandemics, and some of the things that happen in those pandemics that actually are relevant to the pandemic we're in right now, COVID, and sort of what some of the words and concepts that you may have heard in the media or in lectures like this one, what they really mean and what we've learned about those things from past pandemics. So I will get started in a second. If you have questions, I believe the way we're going to do this is you put it into the chat and somebody else will be watching the chat. And unless there's something that needs to be answered right then, I'll answer the questions at the end of my talk. So if there's nothing else, I'll go ahead and get started. There's been pandemics that have occurred all through history. Some have had more information with them in history, but most of them we just can guess at what probably caused these things. But you can talk about the Antonine Plague, which maybe killed 5 million. We think that that might have been smallpox. The Plague of Justinian, 25 million dead, may have been bubonic. But then we do come to probably what was bubonic plague or the Black Death in about the 1400s, with something like 200 million dead, perhaps. Of course, in those days, they really weren't doing censuses and didn't have good surveillance systems, so we don't know for sure. But even in what we would consider modern times, we have certainly had pandemics. The cholera pandemic in the 1800s, the influenza pandemic in 1918, 1919, and I'll talk on that just a little bit more. The Asian flu that occurred, I would guess, in some of our lifetimes with about 1 million deaths. And then, of course, we're still dealing with HIV/AIDS, which started around 1976. And thus far, there's been somewhere around 36 million deaths. I'm going to talk a little bit about a couple other what we would call pandemics that have occurred more recently, such as SARS, which occurred in 2002. But you can see, as we got closer to modern times, the number of cases and deaths, even though our surveillance systems were better, did result in fewer and fewer. And a lot of that is just because of our ability to intervene on the transmission and, of course, the medical care system. We also go to H1N1 in 2009 that did hit Iowa. Most of you may remember that, and up to about 550,000 deaths. And then, of course, now probably the biggest one that has occurred in modern times is COVID-19, which started a little bit over a year ago. And as of yesterday, we've had 33 plus million cases in the United States and over 600,000 deaths in the United States. I didn't put worldwide numbers down just because a lot of countries don't have very good surveillance systems, and therefore they may be grossly undercounted. But in the United States, we're doing a pretty good job, and I think that those numbers are relatively close to reality. So now we're going to talk about some of these pandemics and illustrate some of the issues around pandemics. So where do pandemics come from? Well, a pandemic basically is an epidemic that occurs around the world, or at least internationally. So where do epidemics come from? Well, there's about 5 different ways in which an epidemic can occur. One of those is emerging diseases. COVID would come under that. The virus has probably been around a long time. perhaps in an animal. But the bottom line is something changes, it mutates, or perhaps it's been in a very small piece of the remote parts of the earth, and humans go there and pick it up. We don't know quite how this happens, but things like COVID, Ebola, SARS, new variants, CJD, chikungunya, Mideastern respiratory syndrome, and a lot of things like recombined flu strains like H1N1, all of those would be considered emerging diseases. Now, they're not the only epidemic threats we have. Sometimes it's a disease that we already know about, but it resurges or gets reintroduced into an area where it has been already eliminated, and it basically resurges. Things like measles, malaria, Zika, and here in Iowa, 2 decades ago, we were actually sort of the center of the hurricane of mumps resurgence. We can also have diseases that change to the point where they can become an epidemic. And we can see that with diseases that have become resistant to things like antibiotics or antiviral drugs. Obviously, you all know that we're sort of desperately trying to keep up with diseases that develop resistance quite quickly. The next one is finding that a lot of chronic diseases may actually have either an infectious cause or an infectious component to it. We're learning more and more about some viruses that actually cause cancer. There have been some viruses that have been associated, say, with some kinds of mental health problems, etc. We're learning more and more about that. The one I can remember the most is when I went through medical school, we were told that stomach ulcers were the cause of type A personality and eating too much hot food. And of course, today we know that Heliobacter plays a very significant role in that disease. And then the last one, which I always feel I have to talk about, is we could have bad players in the world who might take microbes and use them intentionally to cause harm. So I want to go back in time and talk about some of the ones that we do know have been with human beings for a long time. And probably the biggest one is smallpox. And this is a photograph of Ramses V, his mummy. And you can even today still see pox on his face. So this is smallpox. We know that it probably emerged into the human population a couple centuries, probably about 4 centuries ago, probably in places like Egypt or Africa. We don't know exactly where smallpox came from, but we do know monkeypox, which has been in the news recently again. We know that monkeypox and smallpox are very, very similar. In fact, if you get monkeypox, you are immune to a certain degree to smallpox. And in fact, the way you stop a monkeypox outbreak is you give smallpox vaccine. So these are very, very similar viruses. So anyway, we think it somehow emerged maybe 10,000 years ago, adapted to us, but we certainly know by about 4,000 years ago, we were seeing epidemics of it. And since smallpox is so distinctive in its clinical presentation, we can be pretty sure that these epidemics truly were smallpox. And again, we have Egyptian mummies that still have the pox on their face. And we know that it was bad enough that people were striving to find ways of dealing with this disease. And even Hindu priests, way back 1,000 years BCE, were describing the use of inoculum to try to stop smallpox. And just in case you don't remember, smallpox has basically 2 different strains. One is a minor, one's a major strain. Major has got about a 30% mortality rate, whereas minor is only about a 3% mortality rate. So inoculum is where you deliberately give somebody the minor form in order to stop them from getting the major form and having that 30% risk of dying. And then, of course, Jenner vaccinated James Phipps with cowpox after hearing from the milkmaids that they couldn't get smallpox because they had had cowpox. And he vaccinated, Vaka coming from cow, he vaccinated James Phipps, and then, very unethically, tried to give him smallpox and was found that he did not get smallpox because he was immune. And I have to laugh. We still see this link between not getting smallpox and therefore having a very nice complexion and milk. Every time you see a Dove soap commercial, you'll see that they pour milk into the Dove bar, meaning you'll have a better complexion. Well, it comes back to this milkmaids not getting smallpox. So smallpox was called la petite variole, and that's why we come down with the word smallpox. And it was given that name to distinguish it from la grosse variole, and please forgive my French accent here. And you get a gold star today if you have any idea what la grosse variole was. It was syphilis, which back in about the 16 and 1700s actually caused huge gaping ulcers all over the body, and therefore caused basically big poxes. Going on in Bengal, even in the late 1700s, we're having very large epidemics, killed more than 3 million people. And something that surprises people is even in some of our lifetimes, there was smallpox in the United States. The last outbreak was in 1947 in New York, and the last case of naturally occurring smallpox was in 1949 in the US. And in 1966, a global eradication program started. And just, I know we're all dealing with people who are against vaccination, so I had to show you this slide. This is a slide of what happens according to the people back in, I believe, about the 1800s. If you gave somebody cowpox, you would get cows coming out of your body. So if you look at that, there's people who have cows coming out of their noses and their arms and other parts of their body as an anti-vaccination campaign, telling you not to get vaccinated with cowpox. 1945, here is where smallpox was found around the world. And even here when I was going to school in the 60s, we were still vaccinating children against smallpox. We were giving vaccination during the second year of life and the revaccination upon entry to elementary school. I'll just tell you, my lifetime, I was vaccinated when I was 2 years old, vaccinated when I started elementary school, vaccinated when I went into the Peace Corps in 1979, and then vaccinated again about 10 years ago as part of the anti-terrorism preparedness, trying to make sure that we would have some people who, if bad actors got smallpox and released in the population, we'd have some people vaccinated and up to date on their smallpox vaccines. So this is one disease that I probably will never get. And any of you who have the round circle scar on your shoulder, obviously that is smallpox vaccination. But fortunately, smallpox now has been eradicated. The last case of the major form was 1975. The minor form was 1977. Though there have been laboratory-acquired cases since then, those are the last cases of naturally occurring smallpox. And in 1980, actually about 6 months after I got vaccinated to join the Peace Corps, they declared smallpox to be dead. So that is what happens with diseases. We were able to get rid of smallpox using the vaccine. We potentially could get rid of COVID by using the vaccine too, if people would all basically take the vaccine. And in a little while, I'll talk about herd immunity and those kind of things. But I wanted to show you using West Nile as a surrogate to show you how fast diseases can actually spread. Now, this was an animal disease, primarily mosquito bird, but it also has a nice way of showing what happens when you have a very virulent virus get into any population of living beings. You actually get those beings over time changed by that virus. And that happened with the mosquitoes and primarily the birds with West Nile. But horses and humans are dead end hosts, meaning that we get the virus, we can get very sick, we can die, but mosquitoes can't pick up viruses from us and transmit them to another person. We are dead ends. Only birds get the viral replication that allows a mosquito to pick it up. It first occurred in North America in 1999. In Iowa in 2001, we sort of laughed about it when that happened. One bird we think just flew over the Mississippi and died in Iowa. But by 2002, it was in Iowans, and it is still in Iowa. Just to remind you, most of the people who get West Nile don't have symptoms. About 20% get West Nile fever, but unfortunately, but 1% get a neurological illness that can be very severe and can cause death, particularly in the elderly who are most at risk for severe illness and death. So I'm now going to show you a series of maps just showing you how fast a virus can spread across the United States. And this is in an animal. It would probably, or can, obviously we found out from COVID, spread even faster in human beings just because of our nature of traveling and going from place to place. We travel much more than, say, deer, which was a group that was involved in this. But anyway, here's the first year, 1999. It was out in the East Coast around New York. The blue is non-human cases and the red are human cases. So here's 1999, 2000, 2001, and boom, 2002, 2003. So you can see that it just exploded across the United States. And then here's 2004. And you can see now it's starting to go back down. And primarily that is because the birds, primarily birds in the COVID family, which, I hadn't realized that means crows and blackbirds and things, not the virus that we're talking about in humans today. But the birds in that family, the ones that were very susceptible died, and the ones that were resistant were left behind, and this has started to go down. At the height here in Iowa, this is where we saw people and birds and mosquitoes and horses getting sick. You can see it was basically found pretty much in every county, some counties being hit harder than others, but certainly was very, very bad. Now, today, we only have a handful of humans getting West Nile in any given year. And that year we had almost 130. So you can see that the activity has gone way down, but it is still here. And most people that I've talked to that are experts in this area of animal epidemics say that it probably will stay. So let's talk a minute about another disease that started elsewhere and came into the United States, and that is SARS. This is a picture of people in Egypt trying to deal with medical records and figuring out how to get people identified and stopped, just to show that this is something that happened all over the world. Well, I'm going to start out just showing you basically how this got started. There was one person, a physician, who had been taking care of ill patients with an unknown disease, a severe acute respiratory disease, in a relatively remote part of China, but then moved to Hong Kong to go to a conference. This green here is his hotel room in the Hotel Metropole in Hong Kong. And by the time he was hospitalized, he had spread the disease to everybody who lived in these blue rooms. By the way, he was in this room alone. And when they went back into the hotel to try to take environmental samples, they could pick up the SARS virus in these red areas and then by the elevator. But you can see even people over here got it. And these are people who may not have even been around him very much, but they hypothesized that every one of these people probably came within about 6 feet of him, whether that be passing him in the hallway or on the elevators. And this is how fast things can spread around the world. A here is our physician staying at Hotel Metropole in Hong Kong. And then these are all the people he spread it to. And you can see he spread it to people who then went back to Canada, went to Ireland, went to the United States, went to Singapore, and then on to Germany, went to Vietnam. But most people got sick while they were still in Hong Kong and ended up in Hong Kong hospitals. And you can see that one of the things that happened with this disease is healthcare workers were particularly at risk of getting it. So you can see at every hospital, almost every hospital, I should say, healthcare workers became ill with SARS. And I don't know if you remember, but in Canada, they had in Toronto had a huge outbreak. At one point, even had somewhere around 10,000 people under isolation at home. But this is just with one person at a conference, how fast it can spread to other places. Now, I wanted to talk about what a super spreader is. I know that the media throws that term around a lot. I have been unfortunate enough in my career to have to deal with super spreaders twice. A super spreader can happen with a lot of different diseases, not with everyone, but a lot of different ones. Measles is one that we've seen, but this is what happened with super spreaders with SARS, just to illustrate the concept. So here at the top is Esther, that's a name she was just given. She stayed at the Hotel Metropole, so was exposed to the physician. She then became a super spreader. Now, it doesn't mean that she was particularly ill, but she may have had less likely to do things like put their hand over their mouth and nose when they coughed and sneezed, but probably most of it has to do with the viral load in her respiratory tract. But anyway, Esther then spread it to all of the people in this line. Now, you can see that most of these people did not spread it to anybody, or if they did, only spread it to maybe one or two people, especially people in close contact, mother, father, sister, son, father, etc. But what happened is she also gave it to this nurse, and this nurse became a super spreader, and then she spread it to everybody in the second line. Now, again, most of these people did not spread it to anybody else, but one of these people became a super spreader, and this person then spread it to all of these people. So I think this is a very, very good illustration of if you have a disease where super spreaders occur, which we do know occurs in COVID, you can get an epidemic or a localized outbreak or a pandemic going very fast with these super spreaders. Had all of these super spreaders acted like non-super spreaders, they probably wouldn't have spread it to hardly anybody else. And at that point, it would have been much, much easier to control or to halt this epidemic or pandemic. This is just to show you what happened in Toronto. It got into a hospital. So they were having cases sort of occurring and then basically got into a hospital and started spreading, went back down. They started very, very severe infection control and quarantine methods, got it back down. And to the point where the World Health Organization removed Toronto from its areas of being of concern, and then it picked up again. I think this is very, very similar to what we're seeing here in Iowa and other parts of the United States with COVID. We think we're doing a good job, things start to go down, and we start being less concerned about it, start opening up our communities, stop using some of the very stringent infection control methods, and the virus takes advantage of it, probably through these super spreaders, and you go right back to where you had started, unfortunately. And these are things that came out of SARS, and I think you'll see that they're very, very similar to what we're dealing with today. Confessionals and using of thermal scanners, which I'll just tell you in the SARS epidemic found to be pretty useless, the thermal scanners at airports. I don't know of a single person they caught with SARS at airports using thermal scanners. And then, of course, all of the cartoons that come up, and you can see that we're seeing all of these again, coming up with, the social distancing, wearing of masks, etc. So I'm going to talk next about Ebola as another example, but this one was a little bit better in that we got it controlled a little bit faster, but it also was a little bit easier controlled because it was not spread through respiratory route. It was spread basically through contact with bodily fluids. This outbreak started in about 2014, primarily in West Africa, probably started in this 14-month boy in Guinea, and probably that child got it from bats. We know that bats carry Ebola, but of course you never go back in time and know absolutely for sure. Because of the concern, a lot of countries, including the United States, sent both medical and public health teams to Africa, both to help with the medical care and keep healthcare professionals from being exposed and coming down with illness, but also into the community to try to get transmission stopped. We started screening at US airports, quarantining of travelers. In the end, there were somewhere close to 30,000 cases with about 11,000 deaths in the 3 countries, Guinea, Sierra Leone, and Liberia. There were cases elsewhere, but it pretty much was controlled and stopped in that part of the world. Here, we did have about 11 cases, and there was 1 death. 1 was an imported death. So you don't need to look at this in depth, but this just shows basically how it was identified, and then with a lot, this one talks about CDC's intervention, but there was a lot of intervention from a lot of different countries and a lot of different others sending teams and things to try to get this under control. And basically, we were able to stop it in its tracks in this parts of the world. But with this virus, the thing to remember is it is still there. It is still causing small outbreaks in this part of the world. So there is the potential for this to happen all over again. So here's where most of the cases occurred, this part of the world. But again, we were able basically to get geographic control of this virus and hold it in check in primarily in these 3 countries. I did want to talk for just a second about measles, because measles can reemerge, and there's a lot of concern in the public health community right now because of all the children that have put off vaccinations, not because they're against vaccination, but just because COVID made them less likely to seek routine medical care in their pediatrician's office. So again, measles had been around for a very long time. We don't know where it came from. It may have come from distemper in dogs or Newcastle disease in birds, but it was described in the 9th century in a way that we knew for sure that was probably measles. First became reportable in the last century in the United States. We got our first vaccine in 1963 that I'll tell you that vaccine was pretty cruddy. We don't even count that vaccine anymore. And we got an improved vaccine in 1968. That vaccine is counted. We set a goal to eliminate measles in 1978. It is still not eliminated from the world, but we have eliminated indigenous spread in the United States. So all measles that we have today in the United States are imported from another country. We get it stopped very soon after it's imported, and then we just have to wait, and it gets imported again because a lot of other countries, unfortunately, have not been able to eliminate it. We do in the United States have 2 doses of measles, mumps, rubella vaccine recommended for being in school or college. We have 2 doses recommended, or we say required, since 1991. However, if you have a religious belief or a medical reason, you do not need to get vaccinated. And there are some schools in Iowa, elementary schools, where only a little over half of the children are vaccinated, the others are not. So you can understand how that then creates a little pocket of susceptibility that we could get introduced measles into that area or into that school and have a huge problem. Again, we eliminated it from the United States in 2000, but we get it imported into this country. And I always find it amusing. People think, oh, well, you're importing it from, Mexico or South America or Africa. No, most of our measles cases are imported from Europe. Anyway, we have a variety of people who come down with cases, and I'll show you how many cases we have. But measles can be serious, and as recent as 2015, a person in Washington State died of measles. You can have complications of it, and about 1 to 2 per thousand of relatively well-nourished children will die if children are not well nourished, the case fatality rate can go up to even 5%, particularly if they are have low amounts of vitamin A. There's also acute sclerosing panencephalitis, which is rare, but can actually happen up to 10 years after you had measles. So it's a pretty bad disease. What is measles? Here in Iowa, if you see fever, rash, and the 3 C's, cough, coryza, and conjunctivitis, that is measles until you prove it is not, and that person should immediately go home, not, as unfortunately has happened in Iowa, have them wander around a hospital trying to find the laboratory to have their blood drawn. Just to show you, here's our history of the measles vaccine. We have a very good measles vaccine. Basically, most people, 2 doses of measles and you are protected for life. Here's the cases in Iowa, going from a high of 21,000 back in 1935 to we had 2 in 2019. But as you can see, even today, when it gets introduced into Iowa in the last couple decades, it really doesn't go very far because of the high levels of immunity we have in the Iowans. So again, most people are immune. 2 doses, you get about 99% basically immunity for life. Now, people have asked about COVID, and I'll talk about that and the vaccination for COVID. Measles is probably one of the best vaccines that we routinely use. And I'm going to talk about flu, and that's probably one of the worst vaccines we routinely use. And I'll just to tell you, even though measles and mumps are in the same vaccine, mumps immunity is probably much less, probably wanes after about 10 to 20 years, which is why we see outbreaks in college students. Just to show you, this is measles cases in the United States in 2015. And this all started with one person who walked through Disneyland out in California with measles. We, to this date, do not know whether it was an American who had returned, probably from the Philippines, or somebody who was from that part of the world who came here as a tourist, but somebody who had picked up the strain that was going around the Philippines at that time, walked through Disneyland. And I love this sign because it says, thousands of vaccinated people did not get measles here, which is true. So just to talk about mumps for a minute, we've had 2 very large outbreaks of mumps in Iowa in the last 2 decades. The most recent one was in the spring and fall of the academic year 2015 to 16. Started to see a lot of measles come up. We were hoping that with the fall break it would stop. It didn't. We started mass vaccination, and with the 3rd dose of MMR vaccine to boost the immunity to mumps, and very slowly you can see that it went down and has gone down now. And this is one of the reasons why the University of Iowa and other universities around Iowa require full vaccination of childhood vaccines, and in special occasions do ask people to get the 3rd dose. And I'll just talk about influenza for a second. Influenza still is here in Iowa, still running around, comes back pretty much every year, except maybe not last year. But I wanted to show you this because we think this is going to happen again. During 1918, 1919, we had a pandemic around the world with what we think now may have been an H1N1 similar virus of the flu. It was aggravated by the fact that World War I was going on too. But if you look at the crude mortality rate, and the pink is of infectious diseases, you can see a huge spike in those years. We are anticipating we will see a spike like that, maybe not quite to that extent, but we will see a spike that occurred in obviously 2020 and 2021. But that's what happens when you have an infectious disease cause a pandemic that basically is not controlled. One of the things, of course, in those days, they did not have a vaccine. In fact, they didn't even know that influenza was a virus. But they basically controlled it through infection control and the fact that it just basically burnt itself out. Now, most of the people in 1918-19 who got this and died, or I should say a large percentage, were young adults, and it was significantly then cause the death, or excuse me, the life expectancy to go way down. We expect that again to happen with COVID, but probably not to the same extent, just because with COVID, older people are primarily dying, not the young, and so do not have as much impact on life expectancy. But when we start seeing this graph come out in years to come, we will see similar spikes. And this is just to show you what happened in this last year with influenza. Influenza actually did go down significantly. Sorry, this is from the last year that we had that was not impacted by COVID, to show you what normally happens. Last year we had almost no influenza, very few deaths in Iowa, just because the COVID infection control and public health measures obviously stopped influenza also. But okay, so this shows you the red with the triangles at the bottom. That is the United States 2020-2021 flu season. So you can see that we did not see the typical spikes that we saw in the winter. With influenza, it was very low. Now, this has caused some people to be concerned that if we continue to open up our communities, that when the flu comes back this fall, it could be even worse than some previous years, because nobody got it last year. Very few people got a flu shot, and we'll be going into this fall with sort of a 2-year break between people either getting vaccinated or having naturally occurring flu. So flu could be very bad this fall. This is my favorite slides. It just shows a guy in a hazmat suit. In the bottom, it says, or you could just stay home when you're sick. And that's one of the things that's happened with COVID as well as the flu, is people are not getting so sick that they start curtailing, especially in the early stages, they don't really curtail their going into public, and therefore they tend to spread these viruses. So here are just some of the things that we've used through history to try to stop diseases from spreading. We use quarantine, which we still use here in Iowa, isolation, social distancing, and of course in the last year, the use of masks by people when they go outside their homes. So I'm going to talk for just a second about COVID. Well, we know how to control the spread of COVID. We've been doing it for a year. Use of masks by everybody, keeping people apart from each other, whether that be people just basically staying home or social distancing, closing office buildings, doing virtual teaching. And the question that comes up now is how much vaccine/herd immunity do we need to get this taken care of? And we have seen the numbers of cases going down quite significantly, with somewhere around 50 to 60% of our population vaccinated. But the problem is most of the population's vaccinated is the older people, who do not tend to be as social or be as likely to be around large groups of people. And the question really is, with our young adults and children not vaccinated as highly, what's going to happen? So as we see now, some communities are starting to close back down again because of the fact that COVID is taking advantage of the opening up of communities. So how do we reduce risk? How do we know how much dosage of vaccines do we need for these potential exposures? How do we determine who is immune? How much immunity do we get from the vaccine? Do we get from the naturally occurring disease? How long does it last? You've seen in the media, people are already starting to talk about boosters. I think that's very premature right now. But then, and when and how can you open, and what do you open? Some of the concerns are the medical care for chronic diseases has gone down in this past year. Vaccines for its children, just the regular everyday childhood vaccines, has gone down. Elective surgeries have been put off. How do we make the decision of what's okay to do, what's not? And I'll just tell you, those arguments continue to go on, but I would just say that I would tend to believe the science and not the people who just don't want to have their personal ability to do whatever they want to do curtailed. We do have some effective treatment for COVID today, and of course, we have 3 different vaccines available. So what's going to happen in the future? I'll just give you my 2 cents. I think COVID's going to come back this fall. COVID is a coronavirus. Coronaviruses are typically respiratory viruses that come back in the winter. I don't see any reason to think that this is not going to come back and be more likely to spread once we're not outdoors as much and we're indoors, especially if we get children back in school. We know that children are the primary spreaders of influenza in our communities. They may well become the primary spreaders of COVID in our communities also. Is this going to become an annual disease like flu coming back every year? My answer is, this would not surprise me at all if that's what happens, is it comes back every year and every fall we get our flu shot and maybe we get a booster COVID shot. A lot of that depends on how long the immunity from COVID vaccine lasts, which we don't know yet. We've only had about 6 months of experience with this vaccine. We don't know how fast it's going to go down and at what point does it not provide adequate protection. Does the summer heat reduce it? I think it did, but it didn't the first year it came around, but we had a whole population full of susceptibles, which we no longer have. And so that's maybe why it's gone down this summer, but I am very concerned about it resurging this fall. Another question is about what about these new variants? Well, these viruses will take advantage of any opportunity we give them. And the viruses that will take best advantage of our opportunities are those viruses that spread the easiest. It's not necessarily going to be the viruses that cause us to get sickest. In fact, the ones that cause us to get sick very quickly and get very sick are probably the ones that won't spread as easily. But the ones that spread easily and don't make us very sick are the ones that are probably going to continue to emerge in our community. Here's just a picture of COVID, and I think this is of concern to us. We need to keep on our toes with COVID because we certainly do not have this thing figured out and under any kind of control. So the bottom line is, will there be new viruses that cause epidemics or pandemics in the future? My answer is yes. I can't imagine that we're over and we're done with it now. So I do think we will have more pandemics, but I do think as our science gets better, as our surveillance and control measures get better, and our vaccines get better, and we get better at doing these quicker, we will be able to adequately address and control them as long as the communities go along with what's recommended and what is scientifically indicated. So I will stop there and see if there are questions for me. I don't know if anybody put questions into the chat. Let's see if I can figure out how to get to the chat. Okay. I haven't used this before, so I'm not seeing, here we go, chat. Oop. Right. I'm not seeing anything in chat. But somebody might help me and see if anybody else sees something in the chat box.
Not a question in the questions box, but the comment, great lecture and lecturer, and this person also loves your home.
I know, everybody gets to see my house. This is my condo. I only have one table, so you have to see my refrigerator and my sink, but that's the way it goes. Life has changed due to COVID. Any other questions I could answer or comments?
Yes, another question popped up. Do you think that we need to wear face masks for all and all over, not just in the hospital?
I would just tell you what I'm doing. I'm very concerned about the Delta variant, even though I'm fully vaccinated and I even have my antibodies checked, and I know I have antibodies. I donated blood, and they'll do that for you when you donate blood, which was nice. But I am concerned. I don't know fully that the vaccine has as much efficacy for the Delta variant as it does for the original variants. Therefore, I wear my mask when I'm indoors around strangers, basically. If I'm around my friends and it's a small group and I know they're all vaccinated, no, I don't wear a mask. But I'm wearing masks at grocery stores. I'm wearing masks I don't know, when I walk through, I had to go to a meeting at the Y the other day. I wore a mask as I walked through the Y. I just figure I've got masks, I can put them on, I'm not embarrassed to wear them. And if it gives me a little extra protection, so much the better. So I am wearing a mask, and I know our numbers are going up here in Iowa, both in cases and in hospitalizations. Our deaths have not gone up yet, I don't believe, but cases and hospitalizations are going up, and I don't want to be one of those people in the hospital. So I'm going to do what I can that's reasonable to protect myself. So I'm wearing masks.
Okay, another question. Can you share which Iowa communities have only 50% measles vaccinations rates in school-aged kids?
Sure, it's public information. Actually, it's put on the Iowa Department of Public Health website every year. You can go down, and every school is listed and their vaccination rate. The school I referred to was a school that's run by the Maharishis in Jefferson County. It's the lowest vaccination rate. Now, people always say, well, what about the Amish schools? Actually, Amish schools don't do too badly. They're usually not as highly vaccinated as some of what we might call the more usual, normal schools, but they usually are quite highly vaccinated. Today it's usually Christian schools, especially sort of the non-mainstream Christian schools, and then places like the Maharishi School.
That's all the questions we have so far.
Okay. Well, I'm 4 minutes from when I was supposed to be done. That was pretty good. And I'll just do a little ad. I'm coming back in about a month. Since I retired, I've gotten very involved in prevention of dementia. And so I will be giving a talk on where the science is right now about preventing dementia. I'll talk a little bit about some of the treatments and things, and give you my opinion about the one that just got okayed by the FDA, that actually now the FDA has been asked to go back and revisit that. So interesting topic, but I don't know about those of you out there, but there's dementia in my family, and there's a lot of things you can do actually to reduce your risk of getting dementia. So come next month, and I'll be back again to talk about that.
All right, thank you for your presentation.
Thank you very much for having me.